So what I'm going to do is I'm going to lay out a little bit of basic groundwork on this topic that I have listed here, and then I'm going to outline briefly a case. And I want to prepare you for that because I'd like it, if we could, to have a little bit of feedback or commentary from folks who are in the audience. If you're interested to share your reactions or questions or comments to it, to try to frame more of the discussion in your experience, it might also help for the activity to be more useful. There's no pressure, like the kind of pressure we sometimes put on trainees and other folks in the national case conference setting, so it's not meant to be that. But if you have something to share, I'd certainly like to hit the pause button and open up a place for that, just a few slides in here, and then I'll go the rest of the way, and then hopefully we can have a dialogue about things at the end. I'd like to talk about some of the complexities around caring for acute toxicology patients, partly due to the obvious that they have a tendency to some degree, be responsible for why they come to our care. And because they're responsible, we think of their illnesses or their patterns of thinking, behaving, and relating as being directly tied to what's wrong with them, and also the critical illness that they produce. And that, right from the beginning, perturbs doctor-patient relationships. And it makes it so a lot of the situations go just fine if we take control of them and the patients are in a state where they are either grateful for the care or don't resist what's going on because they're not capable, but occasionally things are more complicated than that. And so I wanted to use a case that's a little bit more complicated to start the discussion, moving into some issues around questions of the normal rules of medical treatment that we talk about with respect to informed consent and capacity and medical necessity, and then try to talk about it in ways that are a little bit stickier, but perhaps more germane to the reality of what we deal with when we take care of our patients. And then also try to talk about some things that we have learned from neuroscience about how people make their decisions about things, not just about medical care, but about things in general, especially in situations where there's risk or there's uncertainty or there's a lot on the table or a lot at stake, a lot of the things, again, that have to do with acute medical care. And then depending on what we decide to get into here or beyond, I hope that you find it useful as something to think on going forward. So when we talk about doing things properly with our care, although we don't typically think about it much in hospital medicine, the reality is, as you probably know or have been told somewhere along the way, that any intervention that's performed without informed consent is potentially a case of assault that could land caregivers in court. And if we think about it this way, it would paralyze all of us at the bedside with just about every case we approach. And I know that really a large majority of the folks on the call, or a large number, are emergency physicians primarily. And if you allowed this kind of worry about these folks in their robes with their stern looks, being over your shoulder with everything you did, it would be hard to get your work done every day. The reality is, though, that we are charged with ensuring informed consent. It's inherent to the work of good medicine that we are charged with ascertaining and documenting that patients are capable of being informed and capable of making a decision about each aspect of medical care that is proposed to them. And then if we have incapacitated patients, if they don't have capacity to participate, we either have to work to try to restore them to capacity so they can participate, or identify a proper decision maker in each case and step along the way in order to proceed rightly, otherwise we're in a bind. So I'd like to tell you a story, a case that maybe some of the folks who have been doing this for a while or have looked into the literature, they'll find this familiar. So this is the case I'd like to have you react to. So as you're thinking about it, if you'd like to raise a hand to make a comment, I'd be happy to call on you and unmute. Story starts off as a situation that isn't terribly different from a lot of patients we've taken care of in acute toxicology. A young woman takes a purposeful ingestion of a potentially lethal compound. She has done this before, and actually in this case, she has had multiple acute treatments for purposeful ingestions and exposures over the past 12 months. so multiple times recently. But what makes this situation different is she ingests ethylene glycol, she says, and picks up the phone right away and asks for EMS to come and get her. And then when she arrives in the emergency department, she produces a written advance directive, which she put together 3 days prior to this event. Now, the caregivers involved in really overseeing what to do for her, they didn't get terribly hung up about the advance directive. They were impressed that she did this, and it certainly produced a reaction on their part, but they weren't hung up on the notion that this was paperwork that they really had to take seriously in and of itself. They were impressed that the patient was very clear in saying that she did not want certain things to be done and wanted other things to be done. And what she wanted was she wanted medical professionals to be there with her to provide her comfort as she experienced the evolving toxicity of the ethylene glycol that she expected would end her life. And she didn't want her life saved. She presented right after ingesting it, so she had a clear sensorium and cognition. And in that state, she was seen by emergency personnel and even another consultating doctor to answer the question as to whether or not she might be capable of saying this, that she might have the capacity to understand her situation and make choices for herself along the lines that she was demanding. And another expert consultant, along with other folks in the emergency setting, agreed to the extent that she was not acutely treated, and she did expire the next day. And the coroner who reviewed the case also looked into the documentation, what had been said, what had been written down, and according to the story, the coroner even, quote, confirmed that the patient had capacity and opined that it would have been unlawful to impose treatment on this woman. Just to give you a little bit of background about who she is before you ask or decide on your own or tell, she does have a history of mood problems. She has been known to engage in some self-injurious behavior other than use of chemicals in the past, but she's also taken a lot of substances. And she was deemed to have what was written in the chart as an untreatable personality disorder. And this was the background of who she was before this situation took place. So I wonder if there's anyone who, in hearing this or thinking about it or reading about it, has any comments or questions or perhaps complaints about the situation, any initial reactions to that. It looks like we've got a call in from Phoenix Med Tox. Go ahead.
Hi, JJ, it's Michelle. It's just funny, we've got like a room full of like totally shocked people here. You know, we have this situation, and I can guarantee we would have ignored that advance directive because we have that situation a lot. But I will say we also have had like bioethics physician specialists or trained people come speak to us and tell us that the right thing to do is exactly what you just described. And we're always shocked when we hear it, but I just can't imagine having a well-appearing 26-year-old. I mean, we see this all the time, and we've had people come in with their own handwritten DNRs, you know, right after their suicide attempt, and we completely disregard them. And I guess one of the things I'm wondering is, has anybody ever been successfully, like, prosecuted for assault for saving somebody's life, like in ignoring a DNR?
So this is a great reaction. I'm grateful that you're summarizing the shock of lots of folks, because I think that this does shock a lot of us. It shocks a lot of us in the United States, too, to some degree. So I got a chat question from someone else in the audience who asked what state this took place in. And this case is actually from Norfolk, England. This one is not from the U.S. And so it makes you wonder right away, what are the standards for allowing patients to be in control of their situation this way? And if you decided to take control as a physician, would you be at risk of something going wrong? There have been cases of docs charged with assault or charged with overstepping their bounds, but none that I'm aware of that have been successfully litigated to take a physician in this position who might say, no, I not only am not going to go by what you've written, but I'm also not going to go by what you said. Neither one obtains in this situation, and I'm going to force you to be better. That, as far as I know, there have been no cases in the United States that have been successfully litigated.
Thanks. That's really interesting.
Sure. So it is interesting that you've had some bioethics folks on the ground come to you and say, yeah, this story from our standpoint, from the principles that we know and we use, does hold water, and we think that it was reasonable to do it that way. Did they actually say it was right and also that they were comfortable when they told you about stories like this? I wonder if they did have their emotional experience at all?
As I recall, it's been more like we've discussed the situation and asked them what they advise when faced with something like this. And I think they, as I recall, and I forget all the principles, like, you know, autonomy and everything, but basically, you know, the patient has the right to say no. If they have the capacity, they should be able to make that determination. And, you know, it just kind of went against what seemed right to us, but I do remember them saying that, but I don't remember them describing any specific situation.
Got it. Okay. It's certainly an emotional experience for me just to have read a case like this in preparing some psychiatric background for understanding these situations. So I'm in your camp in being bothered, and I'm not satisfied just by having the argument on principle from the ethicists. I hope that you'll find it heartening that there are some bioethicists who also do argue for a different position from principles that they find are compelling and do hold water. And so, you know, there are some other comments that are coming through in text from some other folks asking questions on the counter of this. In other words, so if you honor the directive and there's someone else in the life of this person who later says, hey, I'm concerned that the reason why this happened is this person had a depression that needed to be treated, and you failed to save their lives when this was clearly a manifestation of something that we can do something about. Why didn't you save my daughter's life or my sister's life? And that's the kind of litigation that actually has had more traction in the courts than the kind that you were first asking about there, Michelle. So that's interesting. There are actually more cases where there's trouble for the physician if the physician does not follow through and override what looks like an advance directive or override what looks like the desires of a capacitated individual. And so it makes some of us have, you know, some ideas about a rather automatic response to many of these cases. One of the comments written in chat here as well, and it's one that was echoed from the tox mentors who taught me in fellowship. Doesn't a suicidal patient essentially negate an advance directive right away from an ethical point of view? And the answer in the ethical community appears to be maybe and sort of and possibly. They're not willing to commit all the way, I think, in part because the bioethics community is concerned about making a blanket statement that might allow patients' autonomy to be railroaded. But they're also saying something that has content when they say maybe. So one example of a maybe could be this. What if I change the story to tell you that this was a 56-year-old woman who was a nurse who had worked in healthcare for 15 years, and when she was 40, she wrote an advance directive that said, I don't want any of these procedures done to me under any condition. And then at age 56, she takes this kind of ingestion, which in order to treat requires some intensive therapies that she has said she doesn't want done on her advance directive. And she is, let's say in one case she is clear thinking, in another case she's not clear thinking. What do we do then? We might argue that we're not planning to do things to her that are going to be protracted and last in a way that she as a nurse thought would be terrible and unethical and unacceptable to her. We're looking at a circumscribed treatment that is life-saving, and we're not planning to have protracted critical care that she may not be interested in. So that might be a counter-argument. But the other argument from her side would be, I thought this through before. I didn't think this through the night before when I was trying to make sure that my suicide plan succeeded and I'm keeping doctors from getting in my way. I thought this through not thinking about suicide at all. I thought this through in order to defend myself against medical interventions that I don't want. And now, 15, 16 years later, the circumstances are very different, and then the weight of the decision is on the doctor to make a choice as to whether or not to honor it. That one starts to get a little stickier. So you can see that in this situation it feels pretty stark and it bothers us, but if you start to wrinkle the details of the case, then it starts to get a little bit trickier about what to do. So I'm glad also that Dr. Rua mentioned that she's had ethicists come by to their shop and they've talked through some of the principles of this. I'd like to outline them again here in relation not just to this case but in general for us, so that you do have a sense when you do bring in other consultants who are supposed to help out, but in reality, I bet in some way actually bother you about the opinions they render, to just give a sense of what their logic is, and also talk a little bit about the law too and the practicalities of this, so that you can feel like you've got a handle on the landscape when you look at cases like this. So I'm going to move forward to this very busy slide, which you're going to see a couple of times during the talk. This is meant to be not a perfectly infallible system or algorithm for every situation that you might encounter, but I've tried to hone this over time to be helpful to trainees who work in psychiatry and consultation psychiatry with me at the hospitals where I am, thinking about how we decide whether or not a patient is able to participate in his or her own care when it comes to what they are facing in the acute medical situation. And it starts with the question of whether or not the patient has a medical condition for which we think we have a treatment. If the patient doesn't have one, or we don't think we have literally any treatment to offer at all, then it's a non-starter and there's nothing to talk about. But note that the first thing that we should be doing, this is the way that the practice of medicine is supposed to go, is that we should be first asking, does this sick person in front of me have the capacity to accept or reject the treatment that I'm offering? And that first break point actually divides this algorithm into two separate sections in the graph. We'll talk later about the fact that there's a place where some patients can cross over from one zone to the other. But note that the first cut point really is about the patient's capacity. So the fact that the folks in the UK were really hung up on capacity in this case of this young woman does make sense to some degree. It is the first place where we think about having to decide whether or not we can or cannot move forward, or the way we should move forward if we're going to move forward in a certain situation. And so when we talk about capacity, we're really talking about having someone in front of us who has the ability to consent to what we're suggesting that we do for them. And it matters ethically because we've decided as a society, and it seems rightfully so, that folks who do have the capacity to understand what's going on with them should have the right of acceptance and refusal. There's also the legal portion of the argument as well, and that is that we assume in the United States that all walking around talking adults are their own decision makers for all of what they would like to do with their lives within the limits of the law, and that includes their own medical decisions. In other words, we assume that independent adults are able to make these decisions unless there's a reason to prove otherwise, unless we have data that says otherwise. Capacity is a slightly different concept. It is not in itself a legal one. It's confined to the practice of medicine. And this is one state's rendering of this. And this actually reminds me of the fact that I got a written comment asking what state this occurred in. This is someone who already knows that there's some unevenness to this discussion that we're having, and we'll talk about that a little bit later as we go. So this is what some of the language has been used to describe what capacity is, and note whose responsibility is to figure out whether or not a patient has capacity. It's ours. It's caregivers who are charged with figuring out whether or not someone can or cannot make a decision for themselves. And obviously, I'm not suggesting that everyone gets a psychiatric consultation, even though I know that there are psych consults for capacity, because it would paralyze you just like worrying about lawyers all the time would if you had to get a psychiatrist every time you wondered whether or not someone could make their own medical decision. So here's what it is, right? So capacity is a physician-determined ability described on the previous slide, and it is specific for given medical situation. So capacity isn't one thing. In other words, you don't either have capacity or not for everything that you might have to contend with when it comes to your health. Every specific situation is a decision-specific issue when it comes to capacity. Really, that fits with this statement here, the idea that it admits of degrees. that higher risk, more complicated considerations appear to require a higher threshold for determining whether or not someone has capacity. This is an interesting concept we're going to loop back around to after a couple of slides, because when we look at the standards that have been put forth by experts in this area, they don't appear to relate to degrees, but the reality of medical practice is that it actually does sometimes boil down to that. So just so we're clear, capacity is not competence. Competence is that quality of all the normal walking around adults in society that we have determined they have unless they come into question. You are a competent individual, meaning you're allowed to make decisions like get married, buy a house, also go to the doctor and get your health care taken care of, spend money how you'd like. These are things that we say adults are allowed to do on their own in the legal system. This is not something that doctors render an opinion about, even if they're psychiatrists, even if they're somebody who seems to be an expert in capacity or decision making. This is a different issue, and it needs to be determined by a judge. Judges often will take the opinion of a medical expert under significant advisement, but it's not the same thing. Also, simply being oriented to a situation doesn't give you capacity for making decisions or having the judgment to do it. And note that it's also not good judgment. It isn't an issue of making a decision that we, externally observing a situation, might determine is the right one or a good choice. It is grounded on different principles. We, as psychiatrists, we often get called, not in every case, as I was suggesting, but in cases where patients have conditions that appear like they might get in the way of making a reasoned decision. And note that depression here or a mood problem is on the list. It's not the most common thing that tends to impair thinking, but it is on the list and might be one that you would think would apply to the case that I had told you about earlier. So how do we really decide whether or not someone has capacity? Well, there was a paper written, first version of this actually in 1997, and then edited and reproduced by Dr. Paul Applebaum, who is a well-known forensic psychiatrist who outlined kind of a criterion-based way of approaching capacity. And this is probably what most of us here on the webinar today would have been taught in medical schools or beyond in residency about what really constitutes having capacity. And looking at this list of things, you can probably see how the situation that I described to you in the case might lead the emergency physician involved, might lead a legal consultant, an ethical consultant, some other folks to talk to that 26-year-old woman and get the sense that she does have capacity for the question at hand. She seems to understand it incredibly well, in fact, right? Because she knows that the substance she drank is lethal. She has a sense of how it will go, and she wants comfort care for the parts of that experience that will not be pleasant for her to endure. So she understands relevant information about her situation. She appreciates the medical consequences. She understands what the treatment choices are, and she is certainly able to communicate a consistent choice, not just in writing, as we said, but also she talks about it clear of mind and states it very clearly. So this is the procedure that we teach psychiatry trainees how to do when they do consultative work, and we talk about a menu of questions that we work from in order to try to get patients to talk through how they're thinking and feeling about situations. And so I won't go through all those details. I'll simply sort of go from there to talk about the whys and the wherefores and some of the details of how things either go right or they go wrong. So when things do fall apart, when patients show themselves not to be capacitated, it turns out that research into this issue shows us that different kinds of patients tend to have failings in different ways. So what do I mean by that? Well, what it means is patients who are on medical wards who don't really have much in the way of significant psychiatric illness, who are facing a medical decision and aren't able to demonstrate capacity, most of those folks struggle in a way that they can understand what's wrong with them, but they tend not to link the data very well to themselves in a way that they can reason and work with the information. This tends to be what goes wrong with medical patients. With psychiatric patients, and meaning when we're talking about patients whose illness primary issue is a psychiatric one for which treatment is being proposed and the patients are deemed to be incapacitated to understand what is wrong with them and what's being proposed, they tend not to have as much trouble with cognating if they're given data to work with. what they fail to do is appreciate their own circumstances and the significance of the situation. If pressed through a research protocol to consider information about an illness, most psychiatric patients can say, yes, if that were a situation, I can see why that would be a problem. I understand why you would suggest a treatment, and I can see what the upsides and downsides would be of a patient deciding to take it or not. But that's not me. That's not what my circumstances are, and I'll tell you why. But then, unfortunately, patients with significant mental illness tend to explain the why in a way that doesn't make much logical sense. So the reason why I wanted to highlight this background of information we have is the study doesn't really fit well with the case that we have, but it actually made me wonder, what in the world do you make of our patients every day of the week? We have patients who are both psychiatric at baseline and become very medically sick through complicated toxicities, pathophysiology, and face things that really do require a fair bit of reasoning or understanding to work through about medical decisions. Now, of course, we have a ton of folks who are incapacitated for global and easy to appreciate reasons, but it just made me wonder about how we should be trying to engage our patients in care when they actually represent both of these categories, depending on where they are in their walk through the medical system. So in order to think about how we do this, it became very clear after Applebaum produced his first couple of articles on this and psychiatrists were asked to do some of this work, that it wasn't operationally easy to simply go forward and look at these four medical principles, these four criteria, sorry, not medical principles, but cognitive principles or criteria, and simply use those as a way to determine in every case whether or not somebody had capacity. Because it started to become clear in the operational work that we realized practically that there was a lot more to talk about if a patient was going to refuse to have a Band-Aid put on a cut on their finger, as opposed to whether or not a patient was going to accept or deny a heart-lung transplant for a serious autoimmune condition. And that, you know, just as I say that out loud, I would think that a number of folks listening would say, yeah, that makes sense. So this was a chart that was produced in a paper that followed some of Applebaum's work to describe how to operationalize. And the idea would be that, you know, if a patient is consenting to what we're offering, if the situation involves a very high likelihood of benefit and a very low likelihood of risk, then in that situation, we don't really ask for many details from the patient about their ability to really understand the situation in all of its nuances and details if they're going to accept it. However, if we're in that exact same situation where the treatment is of high benefit and the risk of intervening is very, very low and the patient doesn't want that treatment, well, then we really want to hear from the patient. We really want him to share his mind with us in a way that we understand why he doesn't want what we're offering. And that intuitively makes sense, it seems. It seems to make sense for the folks who wrote the paper and a lot of psychiatrists who tend to follow this view. And the opposite side of the coin also then obtains, right? So if there's a treatment for stage 4 cancer where the benefit is likely to be very, very low, the risk is very, very high, if the patient says, I don't want that, we say, yeah, that's fine. And we don't ask very much of them. But in that case, if they want to take that poison with the very low likelihood of it extending their lives very much and potentially wrecking the quality of it, we really want to hear from them what their reasoning is as to why they would want that kind of a treatment if we're going to offer it. So the reason I bring up this chart is because although it seems to make some sense to us, I would suggest to you that it's not very logical. Logic would say that there are 4 principles of things that determine whether or not someone has capacity, and you should meet those criteria or you should not. And if you do, you can go forward. If you don't, you don't, and we have to figure out another way to go forward. But that doesn't seem to really resonate with our guts, just like maybe what happened to that woman in that case really didn't resonate well with your guts out in Phoenix or mine here or anywhere else on the call. There's something about a gut feeling about this, but it isn't about logic. And so I want to take a bit of a kind of a tangent here for a few slides, because if most of the content here is stuff that folks have chewed on before and you don't find it terribly interesting, I hope that you'll find a couple of these slides interesting, because I think they relate to our sense of what our gut tells us about good choices and bad choices, or right choices, or what's ethical or what's not, because we actually have some interesting information about how human beings make decisions that really has something to do with capacity and medical choices. And so I'd like to go through that really briefly just to give you a chance to chew on this to see if you find it at all useful. It turns out that although we as psychiatrists or other folks who do capacity assessments walk through those 4 criteria as a way to determine whether or not someone has capacity, it turns out that those things are not at all what normal human beings use to make choices on a day-to-day, moment-by-moment basis. Everything from deciding about vanilla or chocolate ice cream to having a heart-lung transplant, those are actually not the kinds of neurophysiologic processes that people tap into when they have to make choices. Even though we drag them through those processes when we get nervous or we get concerned, or even if we're not nervous or concerned, maybe we're just trying to be good ethical docs. When we want to know if they have capacity, we walk them through those things. In part, I think it makes sense because they relate to the issue of informed consent, and we can't know if someone really knows what we're offering unless they can give us the basics back of what's going on. So it makes sense to be concrete to some degree, but it is worth knowing that neuroscience research tells us that this isn't actually how people make decisions. We know this from some really interesting research done by a great neuroscience expert, Antonio Damasio. He got curious about the case of Phineas Gage, the old fellow you might have heard about who had a railroad spike go through his head, and he survived it, and he was actually able to do most things in life afterwards, even the same way he did before. But he made bad choices about all sorts of things that required more subtlety or more understanding of other people's motives or the consequences of what he would do. And it was really strange because he didn't seem to have any other deficits. His vision was fine, his motor system was fine. He could add 2 and 5 and get 7. Everything was fine that way, but yet he seemed to make really bad choices. And so Damasio was curious about this case as potentially reflective of some things about neuroscience that we hadn't figured out yet. And he was able to isolate through a number of experiments, neuropsychological testing, imaging, looking at injury patterns, looking at patterns of strokes and things like that, to find out that there are some pieces of the brain buried deeper in our brain, not the cortex that we rely on for communicating and reasoning and weighing pros and cons, but deeper, older, evolutionarily parts of our brain that we rely on for other things, like the amygdala, and also the ventromedial prefrontal cortex and the insular cortex. And you can see written here on the slide those different aspects of human experience that those parts of our brain help to mediate. And it's interesting, they are areas of the brain that operate pre-consciously. It's hard to put words to describe some of the actions and reactions that are mediated through those areas, and yet they play a really serious role in figuring out how to navigate our day-to-day lives. This is an interesting study of fMRI data looking at the idea that the insular cortex is an area of our brain that appraises whether or not a situation is fair. And you've probably encountered patients who talk to you about whether or not they feel like they're being treated fairly and compare their experience in the ED to people in the next bed about whether or not they're getting the same kind of treatment or whether or not you would treat me the same way if I looked like the guy in the bed next door or the woman next door, or whether or not their skin color is the same. These kinds of assessments and concerns and sometimes complaints, they relate to areas of the brain that have a lot to do with decision making. So here's where those areas are, just to get a sense of them. So we rely on this big evolutionarily new cortex for a lot of the things that we think make us human, but it's some of these deeper structures buried in connections to the limbic system and in prefrontal areas that really have a lot to do with how we make choices. So, what does any of this have to do with actually making a medical decision and contending with patients? Well, here's a kicker. The insula and the amygdala and the ventromedial prefrontal cortex not only do those things that I've described, but they are also highly malleable by life experience itself. Those brain structures that are essential to making decisions are the same ones whose function is profoundly affected by previous interpersonal experiences, trauma, risk, fear, and unconscious processing, not cognating, but a lot of the things that we don't go at when we think about a capacity assessment. So the parts of our brain that we actually use normally to make decisions are not the parts that we test, and they're also very deeply affected by the experiences we've had in our lives before we ever meet them as patients. So that's why I say here, in parentheses, unfortunately, these key decision-making centers of the brain are affected by previous difficulties with other folks who have been involved in patients' lives. You've probably heard psychiatrists talk about the metaphor of a doctor being like a parent, and this is a place where that might really matter. if patients have been treated very badly earlier on in their lives by people who are supposedly in charge of them or supposed to be looking out for their well-being, they may not approach their relationship with you thinking that you are the smart, wonderful toxicologist who's going to save their lives. They may see you through a different lens. And then the other issue is the bias of recency. So we see this when we see problems of contagion in the media where there's bad behavior on our TV screen and then it seems to be perpetuated night after night when we see violence on the street or we see rashes of suicidal overdoses in populations of teenagers, because recent things that occur tend to make us think that those recent things really do define the landscape of our lives, even if it's just a blip and an outlier time period, and it isn't really the way life is. It tends to bias our decision-making centers. So the upshot is rather important, that although we prize cognition as a reflection of patients' agency to make their own choices, previous life experiences before we ever get to have them open their mouths and describe what they understand or what they know have a lot to do with how they make decisions. Context matters. So the issues that patients are facing, and as I was suggesting before, their sense of fairness in their medical care may have something to do with the kinds of choices that they make. We also know that their feelings matter. And what I mean by integral versus incidental emotions are things that are emotionally relevant that just happen to occur right around the same time that you're being asked to make a choice. So, what if you're sitting in a hospital bed and you get a phone call and you've lost a relative to a sudden death that you weren't expecting to lose while you're at the same time trying to make a decision about your own health? That's an incidental emotional experience. It's not integral to your own health, but there's data in decision-making studies that suggest that incidental emotionality has a lot to do with how we end up actually making a final decision about our own medical care. These are the kinds of complexities that give me pause and make me worried that there isn't much I can control at all about my medical practice, and I worry that there's something wrong around every corner, and there couldn't possibly be a right answer of what to do in any situation, because they're all emotional and they're all challenging. And then the added bonus of the fact that relationship matters. The way that patients perceive us or the way that they're getting along with us has a lot to do with what they do for choices. And this is why psychiatrists tend to consult to situations like this and work very hard at trying to get relationships to go better than they have, trying to slow things down and trying to process what has transpired before and trying to find common ground between people so they can work together, because sometimes the bad decisions that appear to be made don't have a lot to do with really wanting to make a bad decision. They have something to do with making a communication to someone else. You've seen this in your tox patients, right? A lot of folks have taken overdoses or done things to harm themselves, not really because you would believe or even they believe that their goal is to be dead, but they're sending a message about how distressed they are to people around them. And sometimes the most important person they're sending the message to is you. And so one of the added complexities here is that often our acute toxicology patients are very alone in the world. This is something that you've noticed in practice too, I'm sure. They don't often come with someone else who cares about them. They're found in a state of disarray or delirium, or they make the phone call themselves, and sometimes no one comes to the bedside for a while. So in the hot moment of care, even if there is someone around at the bedside, sometimes the relationship with that person isn't functioning very well. And so the fact that all these things have something to do with decision-making really makes this chart that I showed before a heck of a lot more complicated and full of a lot more lines and problems, built into the capacity assessment. So do all these things I've talked about neuroscience have something to do with capacity? I would argue that they do. They probably impact the ability of a human being to be able to reason through things in the way that we ask them to if they're going to be capacitated. They probably have a lot to do with how we get along with patients too, as I was suggesting in terms of the history of patients' relationships. But let's say, despite all that I rambled about in that tangent that you may or might not find interesting, let's say for the sake of argument, after all of this, if you go through the process of using the Applebaum criteria and you try your best with your acute toxicology patient to do an assessment and say, okay, I know that the person in front of me does not have capacity. Sometimes it's easy. Sometimes the patient is so altered and delirious on the verge of coma, there's no way in the world you can have a discussion with them. You know they don't have capacity. But in other cases, it's stickier, like the case I described. Regardless of what kind of case it is, let's say you do have comfort that the patient in front of you does not have capacity. Well, then where do we go? If the patient does not have capacity, the next thing that we are supposed to do is we're supposed to try to identify somebody else who might be able to make a decision for them, right? Because we're supposed to be looking for someone with a working brain to be able to consent on the patient's behalf. This is the way that normal medical ethical care goes forward. Now, working in the emergency room, things are hot, decisions need to be made quickly, and sometimes our quick and convenient argument is we don't really have time to hunt down somebody else to ask whether or not this is the right thing to do. They may have a serious morbid outcome or they may pass away if we don't jump in very, very quickly. And so we jump right in and do something about it. Well, so let's say you have a patient who is very, very agitated but very confused from a toxicologic exposure, and they are saying to you when they're able to get the words out, I don't want you to do anything for me. Let me die, leave me alone. But you've decided they don't have capacity because they can't appreciate the situation. One of the questions that often comes up practically in the care of patients is, what is it that actually allows us to take care of a patient like that against his protestations? And the answer is not the use of a mental health statute that keeps the patient in the bed. When a patient like that resists physical life-saving care that you insist upon delivering, if you've decided they don't have capacity, if you take a look at this diagram, note the mental health stuff lives over here, but this is the capacity side. So if the patient does not have capacity, the issue is not really about whether or not they're mentally ill. The issue is you've decided that they have a life-threatening condition you have to do something about now, and it isn't mental health laws that actually protect you in that situation if you're going to go forward. What protects you is an appeal to the standards of practice in medicine. And these are those 4 principles that Dr. Ruha was mentioning before. We prize autonomy in the United States above all the other 4. We've decided that autonomy is the most important principle, that we don't want to do anything to anybody that they don't want, no matter how acute the situation is. But if a patient does not have capacity, the issue of autonomy is set aside. This is worth knowing. Unless the patient is incapacitated and has written very clearly an advance directive that applies to the situation at hand that essentially substitutes for them so that their autonomy can be recognized, there is no autonomy for the individual in the state of incapacity. And this is the reason why we are supposed to go hunting for a family member or someone who really knows the patient very well to make decisions, because we assume that they know them best and can make a decision that can best honor their autonomy, which is the key thing we're trying to do. But absent capacity and absent the presence of a surrogate, you can see where we likely go next. We fall to the next principle to guide what we do, and on this algorithm, when we jump in and we say, this is a life-threatening situation, I'm going to treat this patient. The thing that allows us to treat this patient, again, is not a mental health law that we use to take away people's rights for 24, 48, 72 hours, whatever your state allows. It is actually common law and professional standards of medicine that allow us to proceed. This is the common law tradition that our immigrant forefathers brought for us in America from England, and it says that any reasonable patient in this situation would want this to be done for them. And that's actually what founds your intervening for that kind of a patient. Again, it's not reliance on a mental health law that allows you to take away people's rights. It's saying this person doesn't have autonomy and they're not well enough, but they have a very serious condition, and anyone who really wants, anyone who was in this situation who had their wits about them would know that they should want me to do this for them. And so the courts are not impressed in these situations with you placing patients on some sort of mental health hold. That's not what you need to document. What we really should be doing here is documenting that the patient's situation is morbid or potentially mortal. We can't identify another decision maker, and we're intervening based on the good practice of medicine and what the law expects us to do as doctors. Because as one of the comments I got in the chat before said, yes, couldn't you be found culpable if you didn't intervene when you had something that you could offer to save the patient's life? And the answer is yes, that's part of our privilege of being physicians. So in that situation, we document the incapacity, we document the medical acuity, and then we move forward. I hope that makes sense. So let's move one more step forward. Maybe it's not a capacity issue. So what if you do have a patient who, by whatever criteria you do use, say the case of the 26-year-old woman I outlined at the beginning, the patient appears to have capacity. So now we can think about returning to the issue of mental illness. This was a woman who clearly has a long-standing history of mental illness, appears to have capacity, she fully understands the situation, and she says, I don't want to be saved, I'd rather be dead. So let's just review a couple of bits of data to make sure we're clear. Being mentally ill does not automatically mean that you're incapacitated. Here's a study that compared patients with schizophrenia to those who have depression, to those who have angina, and to those who don't have any conditions at all, looking at their ability to understand, reason, or appreciate the details of a medical situation. Note that the patients with schizophrenia were the most likely not to be capacitated, but still nearly half of them were able to do all three of these main core things. And the fourth of the core things is just to make a choice about what you want. So essentially, half of these folks would be expected to have capacity. So mental illness does not in and of itself make someone incapacitated. And dementia doesn't do it either. So although a diagnosis of dementia is certainly concerning and we worry about cognitive impairment, especially if you like Applebaum's criteria, note that a good, well-done study shows that you need to be pretty far down the line in dementia before you're likely to not be able to do the things that we expect of someone to have capacity. So we can't automatically say that a major mental illness or a major neurocognitive problem automatically makes you incapacitated for your decision. So here's where it really gets sticky, and this is where I think the differing opinions about that case I presented really come home to roost. The medical situation is deemed to be life-threatening. You're in the ER, you've got a tox patient, they're trying to die in front of you, and you've got a solution. The patient is, however, capacitated to make decisions. Another example might be someone with a whopping acetaminophen overdose. You know, preserved mental status, they understand they're going to die, it will kill them, they don't want the antidote. They're pushing the idea that autonomy is the most important thing. And they get all of what's going to happen, and they're saying don't do anything. What we have for laws to support our ability to intervene does not actually have much to do with acetaminophen poisoning, right? So we do have a history in the United States of intervening for mental illness conditions when those conditions pose a threat to the health and well-being of the individual or to others who they might come in contact with. This is true regardless of whether the patient's mental illness renders them incapacitated or not. So this is not about capacity. This is saying there are mental illness conditions that pose a threat to safety and well-being of both the individual in front of me or somebody else who might come into contact with them. Now, the assumption here is that there is potentially beneficial treatment that will modify the problem too. That's an important thing to remember. Now for centuries, well not centuries, well centuries actually, and even recent decades in the last century, a lot of what we did in psychiatry was essentially isolate people from the rest of society and protect them from themselves. We didn't have much in the way of medications that we could give that would modify the illnesses. So safe provision here isn't merely treatment in that medical prescription sense. Sometimes it's really just providing for safety. Note how in the acute toxicology patient, though, using this legal grounding for involuntary treatment would require an extension of logic because the patient has already come to harm. They're in the midst of evolving physical harm. So you could argue, see this patient's mental illness or chemical dependency that led them to use methamphetamine, whatever the situation was, you see, courts, there is evidence that this person may come to harm from this. They've proven it to me because they've shown up in my ED and they're critically ill. That might seem to a lot of us on the call here as a logical extension, but I want you to remember the law that supports us to put people on a mental health hold is dependent on treatment for the condition in question. So when we're talking about committing people or holding them for these problems, we're talking about intervening by putting them in a safe place and potentially giving them medicines to treat these conditions to prevent them from hurting themselves. The situation we're contending with in the acute toxicology patient is actually different. You could argue that it is an extension of their mental illness or chemical dependency that created the acute thing that you've got, but your proposed intervention by taking away their rights using a mental health law is not to intervene with naltrexone for managing alcohol addiction or risperidone for treating schizophrenia. Your proposal is N-acetylcysteine to prevent their liver from falling apart. And that's not mental health treatment, that's physical treatment. Now, the counter-argument would be, but if I don't save this patient's life, there's no hope of ever getting them the mental health treatment they need. So I want to intervene to involuntarily treat them mentally, but the first thing I have to do is save their bodies, otherwise there's no one to save. And that's the argument that has carried the day in most situations where patients subsequently have taken doctors to court. And so I think, based on Dr. Rua's comment and question, you are grounded here, but I want you to be aware that the law itself, in and of itself, the way it's written in almost every state, is not going to protect you. You have to have an extension of logic that helps you to do this. And why is it so sticky that it's different states operate different ways? Well, this is the problem. Our federal government, unfortunately, a long time ago decided to kind of do the Pontius Pilate thing or otherwise wash its hands of making a final decision on the situation. There was a case of patients in Massachusetts going to the Supreme Court to say, hey, you can't force us to take antipsychotic medications for these conditions that these doctors tell us we have. We don't want to have to take medications against our will. They come with toxicities and we're not interested. The government at the federal level said, well, we're not going to claim that this is unjust, but we're going to leave it to every one of the states to have their own standards about how do you define somebody having mental illness? How do you define somebody as being developmentally disabled, and how does this go? How does this work in the jurisdiction that you're in? And there are actually a couple of states in this country that don't allow commitments of any kind. Most will allow commitment on the basis of mental illness. Some do not allow for commitment on the basis of chemical dependence. Some states actually don't make a distinction between mental illness and chemical dependency, and some do. And so it's not worth me sort of babbling on about all these details because it's different in different jurisdictions. But the bottom line is you do have to know your local jurisdiction in order to know what to do. And this is part of the reason why I think it's worthwhile having a relationship with your psychiatrist. Because hopefully they can help you with complex cases. Hopefully they should know something about the relevant laws in your jurisdiction. And hopefully they can help you with your emotional experience of your patients too. Remember I talked to you about how emotions affect the decision-making processes of patients. Well, they actually affect the emotional experiences of physicians too. And it comes down to being an important issue when it comes to capacity evaluations too. Look at this. When a referring physician asks a consultant to come in for a capacity evaluation, depending on whether or not the physician thinks or does not think that the patient has capacity, there's a wide variation in the likelihood of agreement on the part of the consulting psychiatrist. And there's also data from the same study that says that the physician's emotional state has a lot to do with whether or not they do guess that the patient does or does not have capacity in the first place. And so I can certainly admit to it, and Dr. Rua did too, that we both hear this case and we say, how in the world could we say this woman has capacity? How could they possibly have determined that she had capacity? There's got to be something wrong with her. Well, the other thing is maybe psychiatrists can help you to deal with the other things that make patients difficult too. This is another sort of tangent, and I won't spend a lot of time on it because I realize I'm getting a little short on time. But there are a lot of different kinds of patients who have different phenotypes that tend to get in the way of their good medical care. And a lot of times psychiatrists use a lot of jargon that isn't very helpful, but there have been a few of them who have written good articles that are actually useful to other specialists, and I would argue that Jim Groves is one of them. He wrote the original paper on this way back in 1978, and it's been redux since then. To talk about different kinds of patient behavior that get in the way of good decisions and good medical care. The reason why this matters, I'm going to jump ahead a few slides here, is I would argue that this patient that we talked about in the case has features of all of these different kind of really difficult personality types. Even though I didn't give you much data about her situation, she does seem to be the kind of patient who's very dependent on the medical system. She showed up, after all, 7 or 8 times in the past 12 months with purposeful overdoses. She demands things of the medical system that we don't really want to do. You know, don't do this, but do this for me. I want comfort care, but I don't want dialysis. She seems to be rather manipulative, and she seems very, very self-destructive in a way that she says, well, yeah, I did this to myself, but it's what I want to do, and it doesn't mean that I have something wrong with me. In some ways, this patient is a perfect storm of lots of things that make patients difficult, and part of the problem is we have actually good psychological research and medical backing to Grove's article that says that these are the kinds of emotions that those different kinds of patients produce in us as caregivers. And you can imagine how hard it would be to take care of somebody who you don't want to be around, who you have urges to hurt because they're driving you so crazy, who make you feel hopeless about the situation because it doesn't feel like you can do anything to break the cycle that they're in, and actually make you really not like them very much at all. So you can understand why it would be difficult for people to take care of somebody like this. And I would suggest that it's possible that in the case of that 26-year-old from England, maybe the entire ED staff and the ED doc and all the other consultants had gotten so tired of her that although they had medical principles they could use to back what they did, they may have acted out some of these experiences in a way that allowed them to not intervene to save her life, in a way that felt like what they really wanted to do. I know that may be provocative to say out loud, but as I was saying before, we make a lot of decisions out of a position of non-conscious choice that we don't really always have a lot of interest or words to describe. So the last thing I would suggest is that if you are feeling like you got a sticky situation, if you do decide to call in for help, sometimes it might be worthwhile to be in the room together. This isn't something that we talk about very much in consultation psychiatry, but I think you might suggest this to your colleagues if they'd be willing to play along with you. Being in the room together with the psychiatrist who you're asking for help might actually be really informative. Not only is it practically very useful because you're the expert in the medical care, the psychiatrist doesn't know, N-acetylcysteine from, acetylcholine in many cases. And so they're not experts in the medical care that you see as an evolving need. But they're supposedly experts in helping to deal with relationships. Maybe they can help you to mediate the relationship with the patient in front of you a little bit better while you help them to understand why it's so medically acute and why it would trouble you that the patient would be able to use medical principles to do an end around in a way that doesn't feel like it fits with your professional standards of good care. If you put yourself in the room together with the psychiatrist, you can both learn from each other, you can help each other to navigate difficult patient interactions, and maybe get to a better outcome that may help you. And especially if you're in the room together, you might avoid what could be called the Rashomon effect. I don't know if anybody knows this great movie, but it's a simple little movie, 1950, by a great Japanese filmmaker who puts together this simple story of a samurai and his wife walking through a wood who are taken upon by a bandit. The bandit kills the samurai, and then afterwards, each one of these three characters, the wife, the bandit, and the spirit of the dead samurai, are all queried as to what happened, and they have incredibly different stories that they tell about what happened. And the reality is that each one of the stories is actually consistent with the data and wildly inconsistent with each other. And that can happen when we walk into patient rooms at different times and don't sort of cross-reference each other's perspectives and help each other in the same spot. So if you have really sticky situations, the most useful thing might not be to say, call the ethics consultant or call the consultation liaison psychiatrist, let them spend an hour in the room, I'll go deal with other patients and they can come back and tell me what they find. If they come back and tell you something that makes sense, that might be fine, but if there's something that doesn't make sense, the most important thing might be to be in the room together to avoid either disagreeing in a way that's toxic to the patient or you, or agreeing too easily on the right course of action, which feels like probably what happened in that case in England. So I have a couple of ideas about what we might be able to do differently if we were doing things right. Remember that neuroscience tells us that capacity assessments aren't terribly helpful when it comes to the nuts and bolts of decisions, even though we do tend to rely on them. It might be worth reminding your ethics consultants that there's more going on than the ability to parrot back information. And then if you do like some of that neuroscience information, maybe you can take some of it to heart in a way that can actually affect your practice. Now, I realize that a lot of this stuff happens so fast at the level of the emergency department, and acute toxicology requires decisions be made much more quickly than a lot of these considerations. But I think it's worth at least having these things in your head when you approach the situation, especially if someone else comes in to tell you what to do or what not to do. You can appreciate where they're coming from, and you can work with what they give you for information. And I'll stop there, and if anyone else wants to add some comments here as we're drawing close to the hour, I'd love to have some information. I'm sorry that I went so long, but if anybody has anything they'd like to talk about, please raise your hand now. I'll be happy to bring you into the dialogue. Thanks for your time. I know that the clock is striking 12 or 1 or whatever time zone that you're in, I'll take the host prerogative to linger here another 30 seconds, but if folks have to come off the call, I see some folks who are hanging up, and that's A-OK. I'll linger here for a bit longer because I tend to do so anyway and make sure that we've got things recorded and saved. But I think what I'll do is I will call the official end, and again, thank you for attending, and also thank you for your ideas about folks who practice in other areas that relate to the work that we do in toxicology. If they have something to bring to the table, please bring your ideas for speakers to Steve Walsh or to me. Feel free to contact those speakers yourself and try to rope them in and recruit them and turn them on to the idea of coming and joining this activity. The next time we'll get together will be the second Tuesday of October, same time, same station, and I will sign off for now. Thanks so much. I appreciate it. See you next time. Bye-bye.